Well, thank you very much, and good afternoon, everybody. I hope you're excited about starting the conference. It's really great for me to be here from a personal perspective, as I'm also a product of a field epidemiology training program. I did the one with US CDC, but I've also had the great experience of starting an epidemiology training program when I was working in the Dominican Republic. We created a field epidemiology training program there, and it's now, I think, in the 6th or 7th year of their program, and really for me that's also been a kind of life-changing experience to see capacity growing in a country where before there was maybe just interest or unstructured learning around epidemiology, and then to see that transformation through an epidemiology training program. Like a lot of epidemiologists, I'm quite passionate about the training programs, and so it's a really great pleasure to be here. And I enjoyed the dynamic this morning in the meeting about you all talking about your own programs and your enthusiasm. It really is a great pleasure for me to be here. I've recently joined WHO. I've been there for about a year now, and as you all know, WHO is coming through a very difficult period in its history. And I thought it would be interesting for me to provide you maybe with a bit of an update and insight as to what are the types of things that we're doing, really trying to get WHO back on track when it comes to emergencies and epidemiology. And then I also wanted to share with you some of my personal reflections about the role of epidemiology in emergencies in particular. And although we often think that field epidemiology and emergencies are somehow the same thing, actually there's some subtle differences, and I wanted to share some of my thoughts around that. So in the 69th World Health Assembly, which was in May last year, all the member states of WHO agreed that WHO should create a new health emergencies program. We all have witnessed in one way or another the challenges and failings of WHO as an organization in West Africa, and as an organization that's there created by member states, the member states agreed the creation of this new program. The focus of WHO under the new Director General is summed up in 3 focus areas: to keep the world safe, improve health, and serve the vulnerable populations in the world. And all of those components have a direct link to health emergencies, and also towards driving the development goals. What we do is really is a very fundamental part of what WHO is there to do. The Health Emergencies Program itself has several functions, and this pyramid shows some of those functions. The foundational function really is surveillance and early warning, concepts that you'll all be familiar with. Epidemic prevention and control, implementing the international health regulations, monitoring and evaluation framework, which I believe you'll also be fairly familiar with, building capacity, and then when necessary, responding. All of those activities are supported by an agenda of developing guidance standards, leveraging new scientific information, setting policy. So it's a very ambitious agenda that the WHO's member states, all of the countries where we're citizens of, have set for WHO. So just a quick word about structure, because it's maybe confusing when you're speaking to people to know who's doing what and where. The key piece of the Health Emergencies Program is that their member states wanted a more direct link between what's happening in Geneva, what's happening in the regional offices, and what's happening in the country offices. So in blue, we have a number of headquarters departments, and I run one of these headquarters departments. And then one of the interesting things is that structure and headquarters is mirrored at each of the regional offices. So there is a team that has the same function as the headquarters team in the area that I work in. And we actually were just meeting a couple of weeks ago. And then at the country level, there are a number of priority countries which also have similar functional areas. So we're trying to tie in what has been a fairly stormy relationship sometimes between the country regional headquarters office and WHO. So that's all I really wanted to say in terms of an overview. It's an opportunity for me to let you know about some of the changes that are happening within the organization. And now I wanted to shift into really one of the kind of more central focus of my presentation, which is to give you an overview about kind of what my department does. And the reason why that's interesting, I think, for you is that my department has been set up especially to provide essentially the epidemiology type functions that you've all been training in. And we provide a cross-cutting service really to all of WHO. And we're not disease specific, we're not hazard specific either. We work in all hazards. And so I think it would be very relatable for all of you. So what do we do? Well, we do a number of functions which pre-existed the department and which exist really in every single public health agency and ministry around the world. We focus on detecting new public health threats, and we do that through a number of different means. We use event-based surveillance, we use more traditional surveillance approaches of reporting laboratory results and counting those up and having weekly, monthly bulletins provided by ministries of health. And we also hear about things that are going on through our partners and networks. So we're really out looking around the world every single day to see if there are new events, scary things happening, unexplained things that are occurring. When we find out or hear of something that we're concerned about, we need to verify that. And the number one way we do that is we reach out to the Ministry of Health and we say, or ask the question, do you know about this event occurring in your country or in the populations that you cover? And then we also work with our WHO country officers, and again, occasionally with partners, and we deploy field teams as well. We then have quite an interesting process of risk assessment, and I'll talk about that a little bit more. And that's something that you might be familiar with in the abstract or in a somewhat academic sense, but what we've done is we've really integrated that into part of our decision making. And so I think that's a fairly novel approach for WHO. And that responds to a direct requirement from the reform process, in that the global public health community wants to know what WHO is thinking and what its assessment of a situation is, and it needs documentation. So we need to be able to tell and explain to all of you why we think an event in X country is of high concern or low concern. Then, as I mentioned, we get involved in quite a number of field investigations, and some of those are true textbook epidemiology investigations of new events. And then there's another work stream which is around monitoring how effective our responses are. And this is really, I think, a bit of a challenge for us as epidemiologists, because we're not often trained or oriented in the part of the operational parts of our response. We're thinking more about the diseases and the epidemiology, but really we need to be thinking about the impact of our interventions and the effectiveness of what we're doing. And then finally, we do a large amount of reporting, and reporting in all different ways. So at least in my department, we're the ones who turn the handle for the international health regulations reporting through, to the national focal points globally. We have public-facing communications through a website called Disease Outbreak News, and then we do quite a lot of internal reporting, which is obviously not visible to the people on the outside, but is a really critical part of what happens in any public health institution internally is that as epidemiologists, if we're not communicating what we find, then we're not doing our job. So this is, I think, almost a philosophical challenge sometimes, that people feel that reporting is somehow linked with a kind of a top-down, performance monitoring type activity. It's not. If we're not communicating the results of what we're finding, then we're not achieving our terms of reference. So practically, what are we doing? So, well, we're, as I mentioned, scanning the world for pieces of information, trying to find out if there are any concerning public health events. At the moment, we process about 500,000 pieces of information each month. And so that could be anything from an email from one of you, or it could be something posted in ProMed, it could be something written by a local newspaper and published online. So really, almost any piece of information we'll put into the machine and try and make sense of it. We distill those down, we deduplicate that, and then we end up with, at the moment, about 5,000 signals screened each month. So that's a few very dedicated individuals on my team on a daily basis going through essentially long lists of information about events and trying to pick out what feels important. And I know that's a rather difficult issue to communicate, is how do we decide what's important? Well, it's experience, essentially. And this is where computer algorithms can't help you, and it's where professional experience is very, very important, when you get that sense that something might not be right. We go from these 5,000 signals to about 300 events each month that we consider are of sufficient concern that we want to know more about them and make sure that there is some follow-up ongoing. And then we probably end up with about 10 or so formal risk assessments each month to determine how concerned we should be about those events. So you can see it's a process of systematically looking, assessing, looking and assessing. And on the right-hand side, your right-hand side, is just an example of how this played out when there was an Ebola outbreak in the Democratic Republic of the Congo earlier this year. The illness, the index case actually became ill on the 27th of March. And it took, as you can imagine, there were a couple of generations of cases, and then it took a while for that event to be reported. In this case, it was actually reported by a very astute nurse in a clinic who then reported it up through the Ministry of Health. They reported it to the WHO country office, who then reported it eventually to us. And so the in-country team found out about it on the 9th of May, and then on the 10th of May, they sent a team out to start the verification and investigation process. So this is obviously the kind of response we'd like to see, and the kind of response that has not been reliable, when WHO has not been able to reliably deliver this type of result in the past, in the recent years. So we can do it, but now we need to be able to be reliable at doing it. And anyway, so you can see a sequence of events of verification and then engagement in this response. So what are some of the tools that we're using? So this is a screenshot of a tool that we've just put together. I think it's now only 5 or 6 weeks old. That as an organization, we had no way of even visualizing what's been going on around the world. And as you all know, working in ministries of health, being able to get a sense of what's going on in the populations which you're responsible for is extremely important. And so we've put together essentially it's a dashboard that shows all of the events that we're dealing with, and this is available to the Director General of WHO, and he can click through and see what's going on, and then ask questions as to, are we making progress? Why have we not updated the information? Why are we moving too slowly, or something like that? And then other people at different levels of the organization also have access to this, and that allows us to also share information internally as an organization, as a group of public health professionals. So what have we got? Well, I pulled these numbers this morning. So from this morning, we had 135 different events that we're following up to this morning around the world from all different countries. And of those 135 events, 46 of those have been formally assigned a grade level. And a grade level within WHO means what is our institutional commitment to responding to that event. And so a grade 1 event is an event that's been managed purely by the country office, and they're in the lead. And there's a mechanism behind that by which we now support with funding and some staff deployments if necessary. There are 16 events at a grade 2 level, which means they're led by the regional offices, and then 9 events at the grade 3 level, which means they're led by headquarters in Geneva. So that just gives you an idea of the dynamic of what we're dealing with currently. For each of those events, we have a more detailed information set, and that's captured in actually quite an old system. It was created in 2009. It's called the Event Management System, and that's we've really kind of rebooted that system, and that's a way that each country office and regional office can provide information about the epidemiology and the response that's going on. Something that's coming online very, very shortly, we're in the final testing stage, is a new platform for event-based surveillance. This platform is called Epidemic Intelligence from Open Sources, and this is the next generation of event-based surveillance following the current system, which is largely developed by the G7 countries. And which WHO has really been in following and not in the lead of this. But April next year, it's up and running in a testing environment. April next year we'll start using this system. I won't go into too many details, but when I mentioned that we're looking at 500,000 pieces of information each month, well, this is the tool that's going to allow not just us to be able to look at it, but in the midterm, our goal is that all of your countries will have access to this and also look at the same types of information. At the moment, similar tools are only available to a small number of countries and WHO. So this is going to be a big, exciting space in terms of surveillance for public health events. Verification. In the end, you're going to have to get on the ground and go and see what's happening. When I learned field epidemiology, that was kind of one of the principles of it, is that don't make assumptions. Go and look for yourself. There's nothing that can really substitute a field visit. So where at all possible, especially where security permits, and that's a big challenge for us, we go out and have a look. Assessing risks of these public health events. Again, this is something that we all do naturally. Obviously, we're all assessing risks for everything that we do, from crossing the street to planning a long trip somewhere, whether we need vaccinations and so on and so forth. What the world is expecting of WHO is that not only are we assessing risks, but that we can explain why we think something is concerning and why we think something is not concerning, or when we think there's a change of risk from a high risk down to a low risk. So we've been using a methodology that actually comes from a late 1980s series of reports around environmental health risk assessment and has over time developed into a public health risk assessment approach. I'll put a copy of the cover of that document. Is written in 2012, so nothing new there. It's a fairly academic document, but what we've done is we've taken that and we've started, our starting point has been what decision makers need to know. So the document is written backwards. So we start with our conclusion, and then as you go through the document, it gets increasingly detailed, and the justification for our decisions are really at the end. So what you have is, this is just, again, another screenshot, just to give you an idea, is the first thing you see on the page is what our risk assessment level is. And this has been a bit sliced, I apologize for that, but then we write a risk statement. So this is what anybody in WHO who's involved in this event can say, you know, we have an agreed statement about what we think the risk is, which is actually extremely useful if you're at the sharp end of responding and you're in country or at a subnational level and you have to say what we think as an organization. We've written it out and everybody can understand what our risk assessment is. We share these with partners. We don't put it on the website, and the reason is that we don't want to limit ourselves to only including IHR officially sanctioned information. So we want to make an independent assessment of what we think the risk is and then communicate that. And sometimes that is at odds with what the host, with a host ministry says. And we have to manage that difference of opinion, but it's one of the things that WHO really suffered from and continues to have to work through is its balance between independence and at the same time serving member states. So this is what we've done through September. Actually, we're up to just coming up to 100 different risk assessments now. When the people who were designing the emergencies program were thinking about this piece of the program, they thought that maybe WHO would do 10 a year. So they got it really wrong. And this has actually been a very critical piece of what we're doing, so that we're really getting a much more rigorous approach to figuring out what risk is. And the reason why this is important is that as epidemiologists, we're often focused on managing diseases, but actually we should be managing risks. From a management point of view, from an emergencies point of view, it's all about risk management rather than disease management per se. And then the other couples of bits and pieces of the mechanism is the event information site, which all of you, or many of you, I think will be familiar with. It's the way that WHO communicates to national focal points. So we then share information. That's been challenging, and that's also got a challenging history, which we're trying to be faster and clearer about communications with national focal points. And then we have, as I mentioned, a public-facing way of communicating through a site called the Disease Outbreak News, which is a little bit old-fashioned, I've got to admit, and hopefully we can refresh that next year. But this is the way that we share information with the public about outbreaks. It's still the most accessed webpage on the WHO website, so somebody's looking at it. So that's just an idea about what we're doing day to day and how the kind of things that we do hopefully are familiar to the types of work, the types of things that you do in your ministries. So I mentioned that I also wanted to share with you some reflections about field epidemiology in emergencies and why it's in some ways a little bit distinct. And when we're thinking about what we're doing in an emergency, in essence, we're trying to provide information for better decisions. We want our efforts to result in a better public health decision. And so that might be an epidemiological description. We might sometimes be involved in investigating causal agents, risk factors like that. I mentioned health needs assessment. Increasingly, it's important to focus on the mechanisms of health service delivery sometimes, or vaccination coverage, rather than just the diseases themselves and their impact. And that's something what we don't do very well, to be honest, is that we don't measure impact well enough. And then occasionally we get involved in research. But from a response point of view, our main focus is on improving decisions by whoever it is that's in charge. So I wanted to stress to all of you the importance of descriptive epidemiology. Now, when we learn epidemiology, this is often seen as a stepping stone into some kind of analytic approach, whether it's a case control study, a cohort study, applying some regression modeling to a set of data, and we often skip over that and run to something more exciting that's on the computer screen. And I really want to challenge you all by saying that from my point of view, the most important thing, and I look at outbreak reports, maybe a dozen every single day. For the last year, I've been looking at outbreak reports from every country around the world. And a good descriptive epidemiology for emergency response is completely invaluable. It's much more important than something with a p-value. So oftentimes we think, okay, is person, place, and time, we need an epi-curve. Yes, we do need an epi-curve, and it needs to be robust, and we need to label it properly. This is not well labeled, with date of illness onset or data report or whatever it is. But then there are other things that we can do which are really can be very powerful. So this is an outbreak of Legionnaires disease that we investigated at the beginning of the year. And one of the hypotheses was that some of the individuals these were travel-associated cases of Legionnaires disease. And so the question was, well, are these individuals maybe being exposed prior to arrival in the country where we thought they were getting exposed? And so we did something really simple, which is we just plotted the length of time that they were on holiday in in Dubai, which is in the red bars, and then in the black dots is when they became ill. And you can immediately see that these are not people who are getting exposed and arriving in Dubai sick. These are people who were in Dubai and then became sick afterwards. So no fancy epidemiology here, but a good visual description was a really powerful way to have this conversation with the health authorities there. We can get really complicated with visual descriptions in a way that it's very difficult to do either statistically or even in a narrative way. So this is a transmission chain from Ebola in Guinea. I'm sure you've all seen similar things like this. We can put a lot of information that you can understand really quickly, and then you can keep looking and getting more into the details. But we can convey a lot of information through visual ways, especially when it comes to chains of transmission. We need to do some more work on making this process a little easier, but this is a classic approach that you can find going back 100 plus years in the literature. And then, sometimes we're getting more and more into more complicated approaches, but again, really important. So this was actually in the 2009 influenza pandemic, and we really needed to know at that time whether this new virus, this new influenza virus, had any kind of different epidemiological characteristics. And in this instance, we were looking at virus shedding, and we were also looking at what signs or symptoms are correlated with virus shedding. And so, not surprisingly, something we know already is that with illnesses like influenza, when you cease being febrile, you tend to no longer be shedding virus. But these things are really important if you're dealing with a new pathogen. And the reason it's important for us to be doing this type of stuff routinely is that, okay, this time it's influenza, but next time it might be something else. And you don't want to be doing something like this for the first time when you're really under pressure with a new disease. So if you've done this before, it gets easier the next time you have to do it. And then I think this is the last example I wanted to mention, is that we also need to think kind of strategically when we're dealing with epidemiology and emergencies. And sometimes looking at the right population is important. And occupational groups, as you intuitively know, are very, very important for us to understand some of the exposures and risks to the general public. And I just put this one out because it was a kind of interesting experience in that this one we did some more analytic work, and we got a couple of odds ratios, and we found that for these firefighters working in a fire, responding to a fire of an oil storage facility, that people who were working close to the fire had more respiratory symptoms than people who were a long way from the fire. That's not that interesting, or that surprising, I should say. Well, what was interesting was that there was this interesting confounding with wearing a face mask. So people who wore a face mask were more likely to have respiratory symptoms than people who did not wear a face mask, which initially is a bit counterintuitive. But then we realized quite quickly that they were wearing completely the wrong type of face mask that didn't provide them any protection against these products of combustion, and that, not surprisingly, people who were closer to the fire were wearing face masks. So this did actually lead to a change in the standards for respiratory protection for the fire services in the UK. I mentioned the importance of measuring non-disease elements of public health, and this is an approach that has been around for a while, the Health Resource Availability Monitoring System, or HERAMS, and we're trying to I guess, update it a little bit and make it a bit more easy to use. But essentially, what we're doing is trying to measure access to health services in emergencies. And so this is an example from Nigeria. There's been a very large response in northern Nigeria, northeastern Nigeria, 6 million people displaced, and only 60% of the services, of the health services, are functioning. And knowing this piece of information is really important so that we can try and figure out where our resources should be focused towards. So this work could be epidemiology, could be monitoring and evaluation, could be something else. But this, from understanding the full epidemiological picture, this is an important piece of the puzzle. Research is something that we like to think about, but in my experience is very rarely, in emergencies it's really rarely done well enough to turn into generalizable knowledge. I've tried it in a few settings. It's really a very difficult undertaking, but this is one actually that was quite successful. This was looking at virus persistence of Ebola in male survivors in Sierra Leone, and astonishingly we found at least one individual in a very small sample who still had detectable virus in 16 to 18 months after infection. So, this obviously has very, very significant implications for our public health response, and also the way that we engage with these individuals who, and information we provide them and their families and their communities. And again, thinking more broadly that at some point we're all going to be faced with working on a new disease of some sort. These types of studies, actually this almost the identical study was replicated for Zika virus, and now we're realizing, or we're appreciating the fact that actually there are quite a lot of viral diseases that are not normally considered sexually transmitted infections, but we think actually, this is, this might be, significant. So I've given you some ideas about, where I think it's, we should be heading. Measuring our performance globally as a community of professionals is not so easy, but there was a recently published study in The Lancet by a colleague and friend of mine, Francesco Cecchi, looking at how well are we collecting information during emergencies? And he likens this to, if we're in an emergency room and we're looking after a patient, then we need to know their vital signs. So this is the vital signs of a population in crisis. And they looked at a number of different, fairly standard approaches to measuring bits of information for a population in crisis. I won't go through them in detail, but because this is meant to be illustrative. And what this is illustrating is the green portions of those bars are where, in 13 armed conflicts where the information was collected appropriately. And you can see immediately that we're not doing very well. We're not collecting the vital signs of the population in crisis, at least in these 13 armed conflicts. And they did the same thing for several natural disasters, 7 natural disasters. The point here is that we're just not good at systematically collecting public health information about these populations, and we need to do much better at that. One of the approaches is to figure out, okay, what is it that we should be measuring, and then hold ourselves accountable to say we need to measure these elements for all of these crises. And so this is what we've done, so there are these 14 pieces of information that we think we should be collecting, and this, you can find it online. There's a link there about what those pieces of information are. So specific challenges for us. Well, obviously the quality of our data is very variable. And as I mentioned, even at the descriptive level, we're just not doing a good enough job globally. So I think in terms of a quick return on our efforts, I think that's where we can get a good return on our efforts. And then the other thing I've seen, which is again an issue of experience, is that even when we get fairly good reporting of data, there's often no interpretation that comes with that. So I get many EPI reports with many tables and figures and no interpretation of what it all means. That's the art to the science of epidemiology, and that's often missing. We struggle with data collection still. Extraordinarily, we struggle with data collection. Every single outbreak I think I've been involved in the last 15 plus years, it's been a struggle. There are a number of reasons, and it's still a bit of a mystery sometimes why in 2017 we should be struggling still. The investment in methods and tools for us to do field work is minimal at best, non-existent in the most part. And then, as I alluded to earlier on, as epidemiologists, we might not even know what the right information is, or the most important information for a decision maker should be. And we certainly don't appreciate what the timeliness should be. So we're happily working away to produce something that by the time it's ready, the decision's been made and we're too late to impact that decision. So when preparing, I've made these comments in other fora before, and I've always stayed away from giving examples of where it isn't done well, because that's obviously awkward. But some of the things that I see frequently, which we can all fix, is time periods not properly reported. 20 cases of such and such disease occurring in such and such a place. Well, without knowing the time period, obviously that's really difficult to understand what that means. Case definitions. This is a problem for all of us professionally, but we know that case definitions are not well applied, but at least you can say what you're trying to apply, and that's really important. That's almost always missing. This is the third one is something that's been creeping in more and more, and I've seen it in different continents around the world, is epidemiologists reporting non-cases in summary statistics. I don't know where this is coming from, but you see these epi curves with these huge peaks of cases that are determined often by laboratory diagnosis to not be a case, but they still get represented in the epi curve. That's really not helpful. A classic one of the misinterpreting of trends going up or down based on 1 week of data or incomplete data. Again, that still happens frequently. Very rarely good clinical descriptions of cases, and that's especially important early on, and especially important when it's a difficult case definition. And then the laboratory reporting is, for me, one of the issues that I think we all have to work harder at. As epidemiologists, we often want to just know if it's positive or negative, but the modern world of laboratory science is very fast moving, and there are so many different tests out there, some of which are reliable and some of which are not, some of which are are licensed, some of which are not. So again, this is something I frequently come across, is that somebody reports a positive lab result, but we don't even know if the test works or it doesn't work. And there are lots of tests out there which don't work. So getting a little bit more into the laboratory issues as epidemiologists is important. So we've all been in this scenario with data collection on pieces of paper and ending up really the bottleneck for epidemiology becomes data entry. And then what we end up doing very often is we end up having to task highly skilled epidemiologists to deal with data entry and data management issues. It's a problem I think all of us have faced. There are approaches. This is a tool that we use sometimes for electronic entry, but these are not problem-free, and we still end up with lots of data management problems. Tools for field investigations. I'm guessing if we took a random sample here and deployed that group out somewhere, that you'll all be having different tools on your laptop, even if you've done the same training program. Believe it or not, I started learning epidemiology when EpiInfo for DOS was the tool that everybody used, and in some sense, those are the kind of days, good old days, where everybody was using the same thing. And now it's really, for an organization like WHO, which often deploys people to respond as a team, we often find the situation that many of the team members, either some are using R and some are using Stata and some are using SAS and some are using SPSS, and it actually becomes an operational barrier for us. So we need to think about that a bit more as a community of professionals. What are the basic tools that we can all use when we deploy anywhere in the world? We're out. 5 minutes. So there's also expectations management issue, in that everybody, I think, who flew here today would have checked in online and got a boarding pass emailed or sent by text message to their phone. That's the kind of functionality we expect in everyday interactions with technology these days, but that is certainly not the kind of functionality that us as epidemiologists can provide in the field. So when does our job finish from being epidemiologists, and when does it become the job of an informatics specialist to provide some of this technology functionality? There are a couple of approaches or initiatives to try and address some of these things. The Gorn team is developing a tool called Go.Data, which is trying to address some of these issues. And there are other groups. This is a group from Imperial College, which is, or groups based out of Imperial College, which is finding solutions within the R environment to do data visualization and analysis. I've only got 2 more slides, so I'm almost done. And then I mentioned limited investments in methods. And I put this up because I think it's a good illustration of some of the challenge that we face. So we all know that one of the most important pieces of information is our denominator. And without that, really difficult to make sense of our data. But knowing our denominator is often a major challenge. And there's been a lot of effort in creating different approaches to measuring population sizes, but that hasn't really crystallized into an easily implemented approach. So at the fundamental basis, as epidemiologists, we're not addressing this critical piece of information, which is what is our denominator? And then finally, the issue around modeling for decision making. And this is an area that is often seen as very attractive by those of us who are more statistically inclined. But again, it's a question of making sure it's the right question, and the answer to that question is produced at the right time. And we're starting to work on approaches of actually deploying people who can do basic modeling and use quantitative approaches and having them as part of our field teams. So not epidemiologists per se, but people who can apply different quantitative approaches and work at the same desk as decision makers in the field to figure out what piece of information can help them make better decisions. So my final reflections for all of you is that surveillance, early reporting continues to be critical for us as a professional community. We have to make sure that our descriptive epidemiology is good and keep pushing on that and not consider that as a stepping stone or something that's trivial. I think sometimes field epidemiology can get a little bit disconnected from the field, especially when we've got a lot of good electronic tools at our disposal. We've got to keep that field link as part of epidemiology. That's our duty. And then finally, that we as epidemiologists need to really work much more closely with decision makers so that the work that we do is relevant. Thank you very much.
Thank you. Very, 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 very nice. Lots of questions raised with answers. Questions also from our side. I'm, as a decision maker in the European Commission operating, and often looking at the same questions and the ones you raised. We try to do better. We're also, at the same time, one of the main funder of and donator of the responses. And what we lack to do better is also help from your side back, as you said it in the beginning, to report back to us, to report back to the partners in the fields on getting the data that you might get from different sources that we may not get. Gorn, you mentioned, when we send, and when you send teams and we provide input to the teams, very often from the moment they leave the EU, the training projects, MediPIET or EPIET, we don't get any information anymore. And that makes it very difficult to follow up and do better and to try to respond to your question. Why are we sending staff into a dark hole before we're actually getting them back home and then at that moment can do better? Is there any kind of bridging that we can do to make this into a more lively discussion, and maybe every 24 hours or every 48 hours to get a team feedback, be it Ebola, be it Marburg? We have now the lab that we sponsored in Eastern Africa. What are they needing? We don't know. They left and we don't know anymore. So it's really a request, but a very strong request to say, well, help us to help you.
Do I have time for a response, or do I get off the hook? I think a short response, and I'm happy to respond in more fully after this session. We don't have it right yet. I mean, it's very clear that we're starting from our starting point is one of really a very broken communications environment, you know, internally within our own organization and also interacting between member states. And some of the solution is certainly institutional, that we can do a better job, and we can do some fairly simple things, like, for example, in the Ebola outbreak in DRC, we had a weekly phone call with the lead agencies who were providing the response to share information at the senior level. So this is like the agency director, or the one step down from the agency director, you know, with, you know, Red Cross, UNICEF, ECDC, and a number of others. Maybe I'm not sure if we've got all the right constituents there. So there's some simple things, but there's some structural challenges which we all face, such as that as a member state, they might not want to share information about what's going on that freely. So I certainly had experiences, let's say, working in the United States, where the federal level and the state level have different viewpoints about what information can be shared. And then it can become quite a difficult negotiation and take some time to resolve that. And so there are some things inherent to all of our public health systems that might be a challenge that we have to also work collectively on. So what is the right amount of information sharing between different countries, and how do we do that effectively? We're working through that, but there's no quick answer to that one. But I'm happy to discuss some of more details with you.
Hello, thank you very much for your presentation. I think it brought two levels of discussion. One that definitely Frank brought up, so very strategic and very high level, to see how international partners should engage more on the feedback of global missions. And the other one that is more challenging for us, in my point of view, is how to improve the quality of the capacity building and the quality of the training to come up with these basic epidemiological aspects that you brought up in a very good way, because they will have an impact on the strategic level. So it comes to us also to identify what we can do to really have a very good trained who goes abroad in the deployment, that they will have to remember that basic epidemiology is still the very important keys to bring in the field, independently of the tools you can be offering or using the best. And I think that's a very important issue, that we have to find a way that common tools for the outbreak investigation should be one single one when we go on field. Thank you very much.
Thanks, and maybe because we're among friends, kind of professionally speaking, you know, one of the things that we all probably cry a little bit about is the fact that there are a large number of epidemiologists in the world who have no epidemiology training. It's a title that's given to, you know, I mean, in some sense, you know, countries know that they need to have a certain number of epidemiologists per 100,000 population to meet their IHR requirements, but there's no specification about what it means to be an epidemiologist. You know, what are the basic skills that you need as a professional to be able to use the title epidemiologist. So we are quite happy to, we would be very unhappy, let's say, for a doctor, a medical doctor, to use the title without having a medical degree. But somehow we've got lots of epidemiologists. Some of them are actually very, very good. It doesn't, so there's no disparagement to those individuals, but it's still, in some sense, a fairly nascent profession that is not always, you know, we don't always have the rigor as a professional body that sometimes we should do.
Thanks for the very nice presentation, Oliver. I think, especially having an audience here who are all involved in field epidemiology training programs, I think you highlight the needs of how the curriculum of these programs need to be enhanced in the future to move towards unification. And I think, as always, it comes down to who is coordinating the effort and who is giving the advice, so that we actually start using the same tools. or at least generate the same output in terms of data so that we actually have comparable data, especially in these emergency situations. And I'm wondering, who would you think could play a coordinating role in that? And is that, for example, a role that WHO could facilitate in coordination with all these FETP that we kind of have around the world, and the increasing number of these programs as well, especially post-Ebola? If you could share your reflections on that.
I think clearly it has to be a collaborative approach. You know, I think, and I hope I'm not going to put my foot in it when I say, you know, TEFINET is an organization that's established to provide an umbrella for many FETP training programs, so I think that would be an obvious partner. I think WHO has a role to play. I would say in this instance supporting rather than dictating. I don't think anybody wants to have WHO dictating what tools should be used and what should not be used, and I think that would be very much the wrong message. But I do think we need to say, you know, if we, you know, as part of our pre-deployment preparation and part of our preparedness internally in our own countries, we should have a minimum capability. And we all know that it's data management, it's basic, you know, tabulation and some simple statistical manipulation, and then there's some probably some geographical information system and mapping capabilities, and that probably covers most of it. And all we need to do then is probably figure out, you know, which are the most commonly used tools. And then when we get into more sophisticated statistical analyses, then it's probably, I would say, an open question that it depends who's bringing that skill set to the table. But I welcome people's thoughts on it, because as the constituents, I mean, I'm kind of open ears to see what you think the right solution is.
Thank you very much for your presentation. I actually alarmed about one point you mentioned, the challenges, which about this limited understanding of the decision makers about what they need. Is it at the country level or regional level, or is it at the leading agency in response to emergencies, which is WHO? Because this actually, the problem might cost lives if it is any delay in this response. So has it been addressed to the executive board of WHO or the General Assembly, or anything done about this to make it the communication and coordination better? Thank you.
I've seen it at all levels and all organizations that I've ever worked with and for. So ultimately, for most, well, I would say for most of public health events, the ultimate decision maker is in country, maybe the Minister of Health, maybe even the President of the country, depending on the scale of the event. So really, I've seen challenges in getting the right information for decisions at the national level, in national authorities, but also for WHO and other organizations. I would say the most common problem is timeliness. So as epidemiologists, we often worry about getting the best data and making sure it's right and it's clean and all of those things. And even a delay of 24 hours can be too late. And then a decision is taken based on a data-free environment, based on assumptions, based on intuition, and we've missed that opportunity to influence the decision. So I think we've all had that feeling that, you know, should we present dirty data or initial results or preliminary findings, or should we wait for another 24 hours and clean that up and then present it later? I think that's the most common problem, is timeliness. But it sometimes is what is the right information. I think it's a fairly complex topic, which hasn't really been well defined in my view, because decision makers are very varied, as you point out. They could be a local health authority all the way up to Secretary General of the United Nations.
Thank you, Oliver. I'm Vladimir Prikarsky from ECDC. You were talking about threat detection and this huge number, 500,000 of signals in a month. What is
coordination and cooperation with other agencies around the world that are doing, in fact, the same work, how much efficient it is. Thank you.
So the EIOS initiative, the Epidemic Intelligence from Open Sources, will allow all participants to share information about events that they're aware of. And it really warrants a separate presentation. But the idea is that by sharing more between us, then we'll have a better epidemic intelligence about what is happening. Because you might know a little bit of detail that I don't have access to. And if we trust each other, and this is an important issue that we need to trust each other, but if we trust each other, then maybe you'll share that with me, and then I can make a better response. Curiously, I was in our regional office in Manila in the Philippines 2 weeks ago, and the issue they were worried about was that the Chinese government was worried about Chinese nationals leaving Madagascar with plague. And so there was a need for the health authorities in China to understand what was happening in the plague outbreak in Madagascar. I wouldn't have made that connection personally, because but these things happen quite frequently, that different populations or different governments around the world do need to know what's going on in seemingly unrelated outbreaks. So that would be a good example of how exchanging information can help us as a public health community.
Hello, I would like to ask you about, you were mentioning about the laboratories and the results which sometimes are reliable and sometimes not. How are you tackling the problem between, at least between results that originate at point of care, like the Ebola, compared to central labs? How can we harmonize and make sure the results are reliable?
I don't know. Again, I think it's somewhat of a shared issue. I can tell you that, let's say, just from my personal experience working with CDC in the United States, they have capacity to develop a lot of new assays which don't go through a pre-qualification process at WHO. That pre-qualification process is not really designed for new technologies for emerging infectious diseases, so it's slow. And therefore that needs to be addressed. But let's say a group, I mean, it's not just CDC in the US, but that's, you know, a kind of personal experience I had, was that they produce assays which nobody has, there's no proper validation data for. And so, you know, I think we need to ask that question every time we see a laboratory result. You know, what was the test? What was the assay? Has the laboratory itself got proper QA, QC to run the test? We've seen that quite commonly, that you get spurious results. And that should be equally as important as what case definition was used. You know, and there are a whole sequence of questions about, you know, what samples were taken, at what stage in the clinical course were the samples taken, how were they stored, how were they transported? And then all of those things could give you misleading results. But we often place so much importance on the laboratory test results without understanding any of the information behind it. I don't know the answer. I really don't. But it's something, it's a scientific field that's moving so quickly that we can't keep up with it.
Thank you very much. I just, a month ago attended a course of European Respiratory Society, and one of the things that were there was that there is a group who prepares protocols for the event that can arise. I mean the scientific protocols, because outbreaks are opportunities that for research as well as response. Is there anything in plans of WHO to prepare such protocols for research if anything arises? Thank you.
There's a very large agenda called the R&D Blueprint, the Research and Development Blueprint, which is a strategic approach to developing mostly diagnostics and therapeutics for unusual diseases, filoviruses, for example. It doesn't address probably the larger, what might be the larger issue, which is the one I mentioned around, diagnostic assays for more routine things. It's really focused on R&D for unusual or unusual pathogens. I'm not aware that there's I think I think as a professional group, there's some things that we can imagine would be important, and I think links with universities is going to be useful, and there are lots of those already. So I think, I'm a little bit worried. I do worry a little bit about getting too drawn into the research world as field epidemiologists. I mean, we have a role to play, but our core function is, protecting people's health. I feel in a moral dilemma when it comes to research in field epidemiology.